Okay, welcome to Breast Changes Month in the Perimenopause Hub. Today I'm talking to Dr Susie Unsworth, who is our resident menopause doctor, but also who has a specialist interest in breast care. Susie, do you want to tell us a bit more about what you do?
Yeah, sure. I think you might know me already, but yeah, so I'm someone who has got a strong interest in menopause, but in my other role, I work at the breast clinic at Addenbrooke's Hospital in Cambridge. And what I do there, I have a few different roles, but one of my biggest roles is working in the rapid access referral clinic. So I see women who have been to their GP with some sort of breast problem that they're concerned about, and the GP has referred them to the clinic at the hospital for us to assess it further. I guess it's mainly to try and make sure that they hopefully don't have breast cancer. That's the main reason why we see people. But we do see lots of different types of symptoms, and the vast majority of them actually aren't related to breast cancer. So I'm the doctor at the hospital that will see them initially and then arrange for some investigations, which is usually done all on the same day when you get seen up at the hospital.
Cool. So what sort of changes might people notice in their breasts that would prompt them to go to the doctor?
So I think the biggest one that I guess most people would notice is a breast lump. And I guess that's the vast majority of what we see is women presenting with a lump. And there's lumps can come in lots of different shapes and sizes, and we do see a lot of different types of lumps, but I would say that's the vast majority of symptoms. However, there are other things that we do see a lot of. We do see a lot of breast pain issues, and I might go on to talk a little bit about that further in this discussion, because breast pain is actually not a particularly worrying symptom, although women often do get very anxious about it, and maybe a little bit later we could discuss that a little bit more. But yeah, breast pain is something that often gets referred to us. Nipple changes are very common, so things like dermatitis of the nipple is something that I see quite often. And then other changes in the nipple, so if it's become inverted, so that's where the nipple is drawn in, or if people are getting a discharge from the nipple. So these are quite common things that we'll see up at the breast clinic, and I see them most days.
I bet you do. So obviously to notice changes, we're sort of assuming that people regularly know what their breasts feel like. Do you have a sort of a standard way that you advise people to keep on top of knowing what they should feel like, if that makes sense?
Sure, definitely. So I must say, a lot of the time when I see women, they will often admit to me that they don't regularly check their breasts, and they often feel quite worried that they haven't been doing that. So the thing that I would often say to someone is, don't think of it as checking your breasts. I would say think about it as being breast aware, and it's really just getting to know what your breasts normally feel like so that you can identify if there has been a change. And we do have leaflets that we give out, and there's lots of things you can find online about the different ways to check yourself. But the way in which I would often recommend is first having a look at your breasts. I think sometimes women sort of feel like they don't want to look at them, but actually looking at your breasts is a really good way of seeing if anything has changed. And so I often encourage women to look in the mirror. So standing sort of straight into the mirror, then raising your arms above your head like this, and that way you can see if there's any change in the shape of the breast, particularly when they're moving. And then the other way is to then do it with your hands on your hips. I don't know whether you can see what I'm doing in this video particularly well, but hands on the hips, and that kind of tenses the muscles across your chest, and that changes the breast position slightly, and it allows you to see if there's any change in the shape. So what we're looking for is any dimpling, any areas that might be drawn in, anywhere where the skin looks to be doing anything different, anything like that you feel looks different. And it's always useful when you've got two of something, so you can compare one side to the other, and do they look similar? I mean, obviously nobody is completely symmetrical, but on the whole, breasts do tend to look quite similar, although often women will find that one might be slightly bigger than the other. But if you can see something that's notably different between the two, then that's an important feature. So that would be the thing I would suggest to do first of all. And then I'd recommend just getting used to what your breast feels like in all the areas of the breast. And the easiest time to do this is when you're in the shower. And what I would normally say is get your get soap on your hands, so whatever you normally use to wash with, have it on your hands, and then you can examine all the areas of your breast. And it's often easiest to do it with one arm sort of raised up in the air whilst you're in the shower. And I usually recommend doing kind of a wheel spoke sort of pattern. So hub and spoke, I think they call it, don't they? Where you kind of imagine the spokes on a wheel and going sort of like a clockwise sort of pattern around each breast, and feeling it with the middle 3 fingers of your hand, and kind of these parts of your fingers here, not on the tips. You don't want to be kind of prodding yourself, because that's just going to hurt. And actually we're quite difficult to feel things, but doing it with the middle part of your hand. And I'd usually recommend going twice around each breast, sort of gentle pressing the first time, and then maybe slightly firmer, deeper pressing on the second go around. And that way you can just get to feel what your breasts normally feel like, and that way hopefully you'll notice if there's been a change.
Yeah. So going back to pain that you were talking about, what sort of pain do people experience, and what's sort of normal and what's not normal?
Yeah. So on the whole, when someone says they've got breast pain, it automatically slightly reassures me. Obviously I can't say for certain, and you know, I would never say don't get breast pain ever checked, because it's never anything, but the vast majority of the time it is actually just due to sort of hormonal changes. And actually we see it a lot in women in the perimenopause, when their hormones are starting to change, and they'll go through, often it might be some sort of cyclical pattern to the pain, and they might be able to associate it with different times of their just before their period is often a common time to get pain. And I would often say that actually that's not a good time to examine yourself. So when we were talking about doing this self-examination, normally I'd suggest doing that once a month, and I'd normally suggest doing it after your period, because that way it tends to be when the breast is at its softest and less tender. But breasts naturally are tender, particularly premenstrually, so that in itself is not necessarily anything to worry about. However, in some women it can be quite debilitating, and sometimes it can come on as quite a shock, particularly in the perimenopause, when actually that's when we often see the most of it, because women may not have necessarily experienced any significant breast pain before then. But a pain that comes in a cyclical pattern, resolves with your period, and then may start up again afterwards, generally that's actually just normal. And there are things that you can do to help. Looking at dietary things, so cutting out caffeine. Caffeine's a known trigger to really sort of exacerbate breast pain. And then there are things like evening primrose oil and starflower oil that you can use that do have a little bit of evidence to say they can help with breast pain, but you have to take them in quite high doses actually. Probably won't go into loads of detail about that, but it's difficult to manage. I think sometimes it's just about knowing that actually this is normal. You know, I'm not experiencing something that's a sign of anything serious going on. However, if pain becomes so bad that it's waking you at night, and it's impacting on your activities of, you know, just being able to do normal day-to-day things, I guess that's a point where I'd say that probably would be sensible to get that checked out.
So let's say somebody has been checking and they found something they're worried about, and they've gone to the doctor, and the doctor has seen fit to refer. So then they come and they end up in a clinic like where you work. What can somebody expect when they get there? Because obviously it's terrifying at that point, isn't it?
Yeah, well, yeah, definitely. And you know, you've been to your GP with something, and they've agreed that, oh yes, there's something not quite right here. You know, that in itself is worrying. The one thing I always like to say to people is actually 9 times out of 10, it's not breast cancer. So actually the vast majority of people we see in the clinic don't have breast cancer, which is a really reassuring thing. But yeah, it's a frightening time. So what happens where I work is women are seen within 2 weeks, and that's the kind of standard rule that should happen throughout the country. With everything that's been happening with COVID, it's had a little bit of an impact on things. But I think on the whole, we're still able to offer that 2-week turnaround. what will happen initially is you would see someone like myself. So I'm what we call a breast clinician. So I would take the history from you, find out a bit about what symptom you've got, have a chat about how it's affecting you, what things you've noticed, and a little bit about your other medical history. Is there any members of the family who've had any breast cancer? That's something that we do often ask. And then things about medications and things that you might be taking, sort of standard sort of history, nothing too taxing. And then you'll have a clinical examination. So that would be what I perform. And I pretty much do the way I described, examining you. So I get the lady to sit, raise her arms, put her arms on her hips, just so I can see the breast changes, see if there's any changes in the shape. And then I usually lay them down, not completely flat, but laid down is the position that we often examine women in, because it allows the breast tissue to spread across the chest, and it just makes it easier to examine. So we examine both breasts and underneath both arms, so we can see if what we found, essentially. So if there's a lump there, or if they're having any nipple problems, or whatever symptom they've presented with. So that would be the first part of the examination. And what you have is something called a triple assessment. So it's split into 3 parts. So the first bit that I've just described, which is what I would do, is what we call the clinical examination. So that's the first part of the triple assessment. The next part is where you would have some sort of imaging. So you have some sort of scans. So on the whole, this will consist of usually a mammogram. So where I work, mammograms are done on any woman over the age of 40. So any woman that presents to the clinic would have over 40 would have a mammogram, unless they've had one within the preceding 6 months, in which case we would look at that one. So it might be they've had it as part of screening, or they might have been for some other problem and had a mammogram. If you're under 40, we don't routinely do mammograms in women under 40, just because the breast tissue is too dense for them to be able to see very much on it. We do sometimes. It is a little bit of a kind of clinical decision, but on the whole, women under 40, it doesn't really provide us with a huge amount of information. And then, so mammogram would be one of the tests that they would have. And then if we can find an area that feels different, so if there's an actual lump, or if there is an area behind the nipple that we're worried about, then they might also then have an ultrasound scan. And that allows us to look more focused in on the area where there's the abnormality. So that is the second part of the triple assessment. Mm-hmm. The third and final part doesn't always happen, actually, but this is where we might want to take a biopsy. So that depends on what we found on the scans, essentially. So if there's nothing of concern, you wouldn't necessarily need to have a biopsy. If there is anything that shows up on the scan that raises any suggestion of something concerning, then we might well take a biopsy. One of the other things that sometimes happens is if we find you've got a cyst, sometimes we might offer to drain the cyst for you. So particularly if it's very painful, we can actually drain the fluid out, and that can often relieve the symptoms quite significantly there and then. So that would be one of the other potential things that might happen. So that's the triple assessment that you would have.
So if somebody has, obviously, in our 40s, we're likely not yet to have had a mammogram unless we've had to go to this, because we're not yet into the standard screening. What can someone expect from a mammogram?
So people probably hear all sorts of horrible stories about mammograms. I'm sure it's the same with everything, isn't it? Someone will say to you, oh, it was dreadful, it was awful. Essentially, what you're having to do is have an x-ray of your breast, and we need to try and get as much of the breast tissue in as we can. So it does, unfortunately, require you to have your breast placed between 2 plates, and there is a little bit of a squashing action that takes place. So it is a little bit uncomfortable. But for the vast majority of women, it's very quick. Yes, it's slightly uncomfortable for a few seconds, really, but most women tolerate it really well, and it's a really quick procedure to have. So,
daft question perhaps, but if somebody is at kind of either ends of the size of breasts, so either somebody with very, very small breasts or somebody with very, very large breasts, Does that
Yeah.
impact on their ability to have a mammogram?
No, so anyone can have a mammogram, and actually we do mammograms on men as well. So I do sometimes see men in the breast clinic. So it's not actually not that unusual to see men there as well. So yeah, the size of your breast doesn't mean you can or can't have one. And also, if you've got breast implants, I think often women who come up and have got breast implants, they worry about having a mammogram, but actually there's no danger. You can have mammograms with implants as well. And yeah, the sonographers, the women the radiographers that do the mammograms, not the sonographers, the radiographers that do the mammograms are really, really experienced at getting the breast tissue exactly where they want it to be. It does sometimes require a little bit of being manoeuvred into the right position. But so there's no reason that women can't have mammograms. Yeah.
Brilliant. One other thing I was just going to quickly ask, which obviously over the years there's been quite a lot of scare stories about the link between HRT and breast cancer, and I thought we'd probably just do well just to quickly touch on without going into huge detail, because I know we've covered this in other interviews that we've done, but just quickly talking about the lifestyle things that both increase your risk and decrease your risk, and where HRT fits sort of in among those.
Yeah, sure. So I mean, that's a really good way of looking at it. There's lots of different lifestyle things that can affect your risk of breast cancer, and it is helpful to put HRT in kind of perspective with those things. So the risk factors that increase the risk of breast cancer is so being overweight, actually. So having a BMI, not overweight, being obese. Having a BMI of over 30 is probably the biggest risk factor for breast cancer. It's sort of more than doubles the risk. Alcohol use is another big one, and alcohol use increases the risk of breast cancer more than HRT does. Smoking probably is slightly worse than HRT, but maybe sort of in the same sort of ballpark. And lack of physical activity. So this is kind of separate from obesity, but often interconnected. But lack of physical activity actually increases the risk of breast cancer in a very similar way to HRT. So, those things are kind of lifestyle things that a lot of people probably don't think about hugely. But actually, putting HRT in perspective with those things is quite interesting. Actually, being very physically active actually decreases your risk of breast cancer. So that's one of the things that we often encourage people to try and increase their physical activity, because that will definitely have a beneficial effect on the risk.
And I read somewhere, and I only read this because I don't have children, but I read somewhere that not having had children and not having breastfed can increase your risk as well.
It does slightly increase the risk, actually. Yeah. So having children, or having children very late, can increase the risk of breast cancer. And yeah, not having breastfed, it does increase the risk as well. I don't know if I've got the data to hand of exactly the risks of that. And I think it's all to do with number of cycles. It is all likely related to how those things affect your estrogen levels throughout your life. Women who have a very early, start their periods very early and have a very late menopause are potentially at a slightly higher risk because they've been exposed to estrogen for longer. But we're talking about kind of small things and also things that you can't control. You can't control when your periods are going to start, and you can't control when you're going to go through the menopause, but you can control your lifestyle factors. And those are the things, I guess, that we want to try and encourage people to make changes in, because actually they're the things that cause the biggest changes, the biggest risk.
And those are the things that people want to be taking into consideration when they're thinking about HRT, aren't they? Because I know, you hear the scare stories of people saying I can't possibly because of the breast cancer risk, and yet they are people who are inactive or who drink a lot or whatever,
And they're
And
probably not thinking about those as being factors at all. Yeah, they're sort of worried because they might have a family history. So, you know, their great aunt or someone might have had breast cancer, and they're, oh no, definitely can't have HRT. But they drink 2 or 3 glasses of wine every night, and actually, you know, that's much more of a significant risk than actually the HRT would have been.
So to sum it up quickly, would the takeaway be regularly check your breasts? If you find anything different, go to your doctor, and don't be scared that it's automatically something terrible.
Sure. Yeah, I think that's a perfect summary. I would say become breast aware, get to know what your breasts normally feel like. You don't be frightened of touching them. Get to know what they feel like, so that you notice if something has changed. And then if something does change, speak to your doctor about it. So chances are it's probably nothing. Like we were saying before, in the perimenopause, breasts do change, and actually post-menopause as well, breasts change. They become much more fatty, and actually the shape of them can actually change as well. So even that in itself, it doesn't mean that it's breast cancer. But the good thing about breast cancer is it's so much that the treatment has improved so dramatically in the last sort of 20 years or so, that if we can identify it early on, the chances of a good outcome are really, really high, much more so than many other types of cancer, actually. So it's important that we do identify it. And I think that's one message I would say to women at the moment, especially in the current climate, because we have seen a few women who have delayed presenting to their GP because they're worried either about the virus or worried about putting extra strain on their GP if they're having to deal with more serious things. But actually, this is serious, and it's important to get it checked out. And hopefully 9 times out of 10 we might be able to reassure you that it's nothing. But in that 1 time out of 10 where it is something, if we can deal with it early, then the outcome is hugely improved.
Thank you so much.
No problem. Nice to talk to you.
Thank you.